Well, good morning, everyone. Today we're going to talk about capnography and monitoring and how best to represent Bell Medical in capnography. But basically, what is capnography? We're going to talk about the who uses it, where is it used, what is it, why is it used, and how is it used. So that's kind of what we're going to try to do today. And if I can get my PowerPoint. So what is CO2 and how is it produced? CO2 is a waste product of cellular metabolism. So when your muscles do work, they take on oxygen, and then they produce a waste product called CO2, or carbon dioxide. So when any animal or human does work, metabolism occurs, and the byproduct or waste product of the cell is CO2. So CO2 is produced in the cells, it travels through the bloodstream, and it gets to the lungs. At the lungs, the alveoli in the lungs are trying to reach balance because they're releasing CO2 and they're picking up oxygen. So as you inhale, you're inhaling oxygen, and CO2 is being released as you exhale. So that's why CO2 being released from the product is called ventilation. Inhaling oxygen or air is called oxygenation. But at any rate, so that's kind of the process. We are inhaling air, which has 21% oxygen, and then we're exhaling CO2, which is the waste product of the cells based on metabolism. So when you're measuring capnography, you basically have a couple different terms. You have capnometry, which is just the end tidal reading itself. You have a capnogram, which is just the waveform. And then you have what we call capnography, which is a combination of an end tidal CO2 reading and a waveform, and even an inspired or respiratory rate. So it really combines all the things together. What are normal readings of end tidal CO2? I'll let you look at those for a second, but I'll give you the answer. The answer is 30 to 40 millimeters of mercury. So we measure CO2 on millimeters of mercury. And basically, if I have a high CO2, I would basically be not ventilating enough. If I have a low CO2 number, I may be hyperventilating or ventilating too much. So capnography basically provides a breath-by-breath assessment of a patient's ventilatory status. So once again, the readings can be anywhere in the 30s, and that's kind of the textbook range. Waveform represents the concentration of CO2 in the inhaled and exhaled breath, and then all those waveforms together end up with a respiratory rate. So once again, we've kind of talked about this briefly, but as you inhale air, you're oxygenating the body and giving them the ability to take in oxygen, and the trade-off is the CO2 is trying to be exhaled from the lungs. So oxygen is picked up, CO2 is released, and the process of eliminating the CO2 from the body is basically known as ventilation. So once again, at capnography, it's the end tidal CO2 measurement. It reflects ventilation. Hypoventilation and apnea are detected immediately. So basically, if that CO2 waveform goes to a flat line, that means you're underventilating or you stopped ventilating. So you have hypoventilation or apnea, the lack of breath. Whereas pulse oximetry is measurement of the amount of oxygen in the blood, or the oxygen that's being carried by the red blood cells. So pulse oximetry reflects oxygenation, the amount of oxygen in the blood, and from an alarm or monitoring standpoint, its values lag considerably the hyperventilation and apnea related to a patient from capnography. So basically, we used to do tests where you would take a deep breath and hold your breath with an oximeter on, and you could literally go several minutes before the oximeter would start dropping from 98 to 96 to 95, and a lot of people cannot even hold their breath long enough to bring it down. So it could take, especially if you were on nasal oxygen or oxygen mask and you were hyper-oxygenated, it could take 3 to 5 minutes before a saturation or pulse oximeter monitor would decline to a point below 95% or to a point that you get an alarm generated. Whereas with a capnography monitor, as soon as you stop breathing, there might be a delay of 20 seconds where it's looking for a breath, but you're going to get a visual clue that the patient's not taking a breath, and you're going to get an audible alarm within 20 seconds. So here's a study that says cases of respiratory depression or lack of breathing were 28 times as likely to be detected if they were monitored by capnography as those that were not monitored. End-tidal carbon dioxide monitoring is an important addition to oximetry for detecting respiratory depression. So here's an actual waveform and what's occurring. Basically, the A to B section, they say here's a baseline, but it's basically almost a resting period. You've just exhaled, and now or you just inhaled. Now you're about to start exhaling. So the B to C rise is early exhalation, and you're starting to send the CO2 out. C to D is full exhalation, and you get to a point at D, which is the end point of exhalation, where you've completely exhaled, and now you're about to inhale. So that's where we measure our end-tidal CO2 value. And then you start to inspire, and that creates a rapid decrease in CO2, and then you're back to your baseline. So that's the traditional CO2 waveform that you will see. Once again, D being where we measure the end-tidal CO2 value that you'll see on a monitor. So what's an example of an abnormal waveform? Well, there's all kinds, but this is not as precise of a science as an ECG waveform, for example. But the waveform, once again, is, as you look at that displayed there, that's a normal CO2 waveform, and then you have something occurring here, and what's occurring, that could be a flat line, which means it doesn't sense any CO2. In this case, it's almost a flat line, but basically the waveform to zero or near zero means no breath, and you would get an alarm from that. In fact, usually the alarm is set somewhere in here represented by this dotted line maybe, and if it doesn't exceed that dotted line, you'll get an alarm. So common causes of a no breath detected by a CO2 monitor would be the absence of breathing. You know, everybody thinks their monitor might be at fault, but in reality, that patient may be sedated to a point where they've quit breathing, or they need to adjust their neck or their head position so that it opens their airway to allow them to be easy to take a breath. You can have a total airway obstruction, such as an obese person with their head in a position that they can't straighten out and thus can't get a breath through. You could also have a kinked or displaced filter line. So if the filter line becomes disconnected, they're not going to sense CO2. Or if the filter line, the sample line is kinked, it won't. Usually when it's kinked, though, it'll say line block. So that would do. Also, you could have a dislodged endotracheal tube. So in other words, the endotracheal tube is come out from where it's supposed to be, and it's not detecting breath anymore. Why is capnography utilized? Well, it used to be only in the operating room, and it's been in the operating room for 25 years. But now it's moved out to everywhere within the hospital. So you have the original usage, which was general anesthesia. Then we have MAC anesthesia, which is monitored anesthesia care. Monitored anesthesia care is also called procedural sedation or conscious sedation. It's when they are sedating the patient, or they're using a regional block, but they're not doing general anesthesia, but they're doing a procedure on somebody that has them to a point where they're sedated. An example of MAC anesthesia with an anesthesia provider might be a colonoscopy, for example. They also use CO2 monitoring in the PACU. This is probably the biggest growth area. So when you go into an anesthesia department or an operating room, you want to ask, are you monitoring capnography in the PACU? And if they say no, you might say, are you interested in doing that? Because we can provide them monitors, and we also sell monitors, but so that might be an opportunity for you. ICU, they're using capnography primarily for ventilated patients. Sometimes they use it continuously. Sometimes they just come in, the respiratory will come in and spot check their CO2 readings. Sometimes the CO2 capability is built into the ventilator. We've talked about our big marketplace, endoscopy and GI. Probably 5 to 7 years ago, they weren't monitoring endoscopies routinely. They were literally using their hand to feel breath being exhaled from a patient, or they were watching and observing chest movements. Well, the problem is a lot of times they're dimming the lights, they're putting the patient in a position you can't really see very well, and as a result you had issues with patients not breathing and them not catching it right away. Whereas now, if you have a CO2 monitor, as soon as that patient quits breathing because they're over-sedated, you'll see the CO2 waveform will go flat, and within 15 to 20 seconds, you'll get an alarm alerting you to the fact that you need to shake the patient, stimulate the patient, open their airway, or rescue them if you have to. Emergency department is a place where capnography is used often, because they might bring a patient in that's got a dislocated shoulder or a broken arm and they need to set it. Well, that's going to put the patient under extreme pain. So what they do in the meantime is they would sedate that patient. And then they will, as they reset their shoulder or reset the broken limb, that's stimulating the patient very significantly, so the sedation works. But then when they're done with that, they might be leaving the patient, and the patient's staying in that chair or bed or gurney or whatever, and now they're not being stimulated, and the sedation that they gave them earlier can take hold and end up resulting in them stopping breathing. So in the emergency department, whenever they're setting a bone or a dislocated shoulder or anything that's painful, they'll give sedation, and now they should be monitoring capnography, because once again, when they stop that stimulation, the patient could go into a point where they quit breathing. Cath lab, usually the patient's awake in a cath lab, and that's considered conscious sedation because they're sedating them and they're doing a procedure. So they'll use CO2 monitoring there. Pain management, that's become a big area where especially they're monitoring, you might have a patient with a what do they call the buttons they press to give them more pain medicine, and when they press those, sometimes they can get over-sedated. So pain management now in the OR floor, in the basic patient floors, if they're under a opiate or some kind of a patient-controlled anesthesia, PCA pump, they are often monitored with CO2 monitoring because they're not monitored in other ways, and there's not a nurse present like there would be in the PACU or in an ICU, and you can have a patient stop breathing and end up be in serious condition. Also, EMS, they're always using capnography to verify endotracheal tube placement. General anesthesia, the ASA made standard in the OR back in 1991. Patient ventilation. So when you have a patient on an anesthesia machine, it allows the anesthesia provider to control the amount of ventilation, and the CO2 monitor tells them, hey, I'm ventilating that patient too much, or I'm not ventilating that patient enough. For example, if you have a CO2 reading while you're on a ventilator and the anesthesia provider sees that you're up in the 40s or even higher, that means that they are not ventilating you enough. So they would either increase their breath rate from maybe 8 to 10, or they would increase their tidal volume from maybe 800 to 900, for example. So each breath has more air and oxygen going into them. Likewise, if the CO2 value became very low, like in the 20s, that would mean that they're ventilating for you too much. In fact, they're blowing off all your CO2. And when they do that, they would want to basically lower their ventilation or lower their respiratory rate so that they would be in that ideal 30s range. So basically that's how they control your ventilation using end-tidal CO2 readings. Okay. They all use intubation verification, so as soon as they put the endotracheal tube through the airway and put on the circuit, they always look to the monitor to see if they see CO2. If they see CO2, it confirms that they've ventilated the trachea or the airway rather than the esophagus. If you put your endotracheal tube in the esophagus, obviously you're in the stomach and you're not going to get any CO2, and a patient could expire, could die. So CO2 in anesthesia is used as an apnea indicator, so it lets them know when they are not breathing, so it gives you an alarm within 20 seconds. This is a question that's kind of interesting. What do anesthesia providers want end-tidal CO2 readings to be at the end of a case? Do they want them to be high or low? Well, if you think about it, they want them to be to a point that would stimulate a patient's breath. So if CO2 is low, they've been hyperventilating, and thus they're not going to have a whole lot of drive to breathe. So what you'd rather at the end of the case, in fact, sometimes they'll turn off the ventilator and not breathe for a patient for a couple minutes so that the CO2 is building up in their system. So generally you want a higher CO2 reading at the end of the case because CO2 is the impetus for taking a breath. So as you're trying to get a patient to wake up, their CO2 builds up, they'll take their own breath. In fact, CO2 in the brain is basically why you cannot hold your breath and kill yourself, because as soon as you hold your breath, the CO2 starts building in your brainstem, and the brainstem basically says you have to take a breath. So how is CO2 used in MAC or monitored anesthesia care? So those are all procedural sedation or conscious sedation. The other examples we were using was general anesthesia. That's where you're having the patient on a ventilator. So procedural or conscious sedation, the patient is breathing on their own. So CO2 in this case is more used as an apnea alarm to recognize the cessation of breathing of a patient that might be too sedated. And we use all kinds of methods, nasal cannulas such as our split cannula, dual cannulas, which means they give oxygen from both sides and they sample from both sides. And then there's oral nasal cannulas to capture mouth breathers. We have all kinds of monitoring methods. An oxygen mask is probably most often, it's taught to every anesthesia provider. So they all know that they can take an oxygen mask and they can either take a sample line and put it underneath the mask, or they can punch the sample line through one of the holes, or they can take a gel co or an IV catheter and throw away the needle in the sharps container and take the little straw that's left, and they poke that through the oxygen mask hole, and then they kind of push it in a little bit to secure it, and then they'll attach a sample line from their anesthesia monitor and attach the sample line to the end of that gel co catheter or IV catheter. Now when they do that, they get a poor waveform. They basically get the presence of CO2, but they don't get a true CO2 waveform. So it's kind of an unreliable CO2 value. And it's easily disconnected, because if someone touches that sample line, that little straw can get, or catheter can get pulled out, and the next thing you know, you're getting a CO2 alarm when the patient may be breathing fine. We have many oxygen and end-tidal CO2 sampling masks to compete against that MacGyver method. So when they MacGyver it, they're taking an oxygen mask that might cost them $1.50. They're taking a sample line that might cost them $1.50. They're taking a gel co catheter that might cost 70 cents. You know, they ended up getting close to $4 when they're MacGyvering their system. And if anything goes wrong and someone says, hey, I created this system, that gives them more legal liability, versus if they're using a device that is approved and FDA approved, et cetera, to be able to monitor CO2 and deliver oxygen. Those devices would be such as the Capnoxygen mask, the Capno mask, and the Palm mask. All the three of those masks we'll talk about at the end of this presentation, but they give excellent CO2 waveforms. They give reliable values even with 6 to 10 liters of oxygen being delivered, and there's less chance of a disconnect where the sample line will come out. And generally they're about the same price. At least the Capno mask and the Capnoxygen mask are roughly the same price as the MacGyver technique, if you will. PACU capnography is a new standard of care, so you see more and more post-anesthesia care units monitoring capnography. So you want to ask that question, and we can help them with it. So respiratory rate via CO2 monitoring is superior and more accurate to respiratory rate from ECG impedance. So when someone comes to the PACU or the recovery room, they're always, sometimes they're watching chest movements, sometimes they're relying on ECG to give them respiratory rate. Now when they have CO2, they would always default to the respiratory rate coming from the CO2 monitor, because that's true ventilation. So it's just even though in a recovery room there's usually one nurse for 2 patients, you still have a risk of perhaps not realizing what's going on, or maybe not being aware that their respiratory rate is truly low, and this gives them a faster response. Now, everybody in the PACU is also measured with pulse oximetry, but once again, you've just come from the operating room where you've been in an oxygen-rich environment. At the end of the anesthesia, when they're about to take you off the operating room table, the anesthesiologist always delivers 100% oxygen and really oxygenates you. So as a result, when you get to the PACU, you usually have a high saturation rate, usually at 99 or 100%, but that doesn't mean you're breathing. So they put you on a CO2 monitor, and that gives you the information they need as far as respiratory rate. Capnography monitoring in the ICU, it's used for ventilation adjustments, ET2 placement, sometimes they have to intubate in the ICU. It reduces the amount of blood gas draws, and we've talked about pain management, but if somebody's on a PCA pump, it helps maintain their breathing and they don't get over-sedated because of pain management. Procedural sedation capnography, most often for us it's endoscopy and GI departments, and this is where a big money bucket is for Bell Medical sales reps, is to identify your freestanding endoscopy centers or your GI departments within hospitals and identify what they're using now, and then letting me know, and I'll help you strategize on how to sell them. But we have a excellent CO2 monitoring option for any endoscopy or GI department. Let's see. Capnography in the ED and EMS, it's mainly used for ET2 placement, procedural sedation, and resuscitation. Resuscitation is kind of interesting. It's now pretty common on all cardioversion machines and defibrillators is to have CO2 monitoring capability, because CO2 monitoring, when you're doing chest compressions, will verify whether you're doing adequate chest compressions. And if you're doing chest compressions well enough that you're getting some CO2 exchange, you want to keep doing those even though you may not have a heart rate, because you are getting ventilation is occurring. You're moving CO2 out of the system, so that means oxygen is being taken up. So your resuscitation is being effective. Capnography for pain management, we talked about this. There's some examples. We'll talk about of patients that have actually died in a regular floor of a hospital because they've been on pain management. So the Joint Commission came out and said, hey, when you're using opiates in a hospital for pain management, it's generally safe for most patients. Opiate analgesics may be associated with adverse effects, the most serious effect being respiratory depression, which is generally preceded by sedation. So the bottom part here says the opiate-related adverse drug events, including deaths that occurred in hospitals, were 29% were related to improper monitoring of the patient. So a third of them. Here's an example. Amanda, this patient was given a PCA. She was down on the floor of a hospital. This is actually probably more than 3 years ago now. It's probably more like 5 years ago. But the point is that if you or a loved one is in the hospital and they give them a PCA, which is a analgesia, button to give them pain relief, and they're not monitoring their CO2, you should be concerned, and you should demand that they monitor that patient's ventilation or take away the pain treatment. I had a hospital here locally where the patient wasn't even on a PCA pump. They were given oral pain medicine, and once again, they're down the hallway in a hospital, and they ended up dying because they didn't have anybody monitoring them. So a nurse came in just to check them routinely, and they had stopped breathing. So what are the monitoring standards? Back in '86, the ASA approved CO2 monitoring during anesthesia as a standard. During regional anesthesia with no sedation or local anesthesia with no sedation, the adequacy of ventilation shall be evaluated by continual observance of qualitative. So if they're just doing a local anesthetic, you can just observe clinical signs such as chest movements and things like that. But if you're using any kind of sedation, and propofol would be a deep sedation, but any kind of moderate or deep sedation, the adequacy of that ventilation shall be evaluated on continual observance of qualitative clinical signs and monitoring of the presence of exhaled carbon dioxide unless precluded by other situations. So basically, it's since 2011, it's pretty well a standard of care. But you will still find GI departments and various departments that aren't using CO2 routinely. So capnography's use is growing throughout the entire hospital. The ASA now recommends capnography during procedural sedations, MAC anesthesia, GI, endo, all those different cases. The American Association of Nurse Anesthetists came out in 2013 updating their standards during moderate or deep sedation, continually monitoring the presence of CO2. Joint Commission released an alert regarding monitoring patients receiving opiate therapies and monitoring with capnography. And in 2010, the American Heart Association recommended it for resuscitation. American Heart Association and the Europeans also recommended capnography to confirm and monitor endotracheal tube placement and the quality of your CPR. So that's kind of our PowerPoint presentation. I'm hoping I can get out of this now. Let's see. Yeah. And I'm going to try to find a little bit better. And I might ask, I'm going to take you off of mute.
Okay.
Okay. To come off of mute if you want, but I heard some background noise, either with, hopefully with pets or something like that. Hopefully you can see me now. We're going to do a brief in-service of some of our products, so I'm going to tilt this down a little bit so that you can see the actual products that we're going to be talking about. And we'll start off with the most basic, which is our nasal cannula. This is private labeled. It's made by us by a company called Westmed. Westmed is a U.S. company, but most of their products are made in Mexico. I'm not sure what this one actually says. But it is a traditional split cannula. And a split cannula was first came out with by a company called Salter Labs. Salter Labs is a company that we also have access to. And the split cannula means that basically one side is delivering oxygen and one side is sampling CO2. What Westmed does well is they do something called comfort soft. So if you hold their sample tubing in your hand, you'll feel it feels softer versus most other, like Salter uses tubing that's harder, like their oxygen tubing. And where that's important is when you put that around the ear and you cinch it up underneath the neck, it basically stays in place, whereas the harder tubing will pop out, and then next thing you know, this underneath the nose gets placed off to the side, and you get an alarm when you actually don't have any reason for an alarm. Now, we do have other cannulas that are not split, that they might have a hole down here and a hole down here that will deliver oxygen and sample CO2 from the nasal cannulas. But for right now, it seems like the industry standard and acceptance is to have a split cannula where one is dedicated to oxygen, one is dedicated to monitoring CO2. One of the nice things about our Westmed monitoring is that our cannulas are 10-foot and 14-foot long. Most of the Salter cannulas that you run into will be only 7 feet long. So they'll have a number like 4707-25, and that means it's a 7 foot and it's 25 in a box. We sell ours in 25 count or 100 count. So the larger facilities that are using 800 a month, they're much better off buying our 100 count than buying 25 per box from Salter Labs. Our nasal cannula also comes standard with a male connector, which this is the male connector, but it also has an adapter within it that converts it to a female. So whenever you see a Salter cannula that has an F with it, that means it has a female end, which means they're probably taking a sample line from an anesthesia machine, and which ends with this male connector. And obviously, if I have this, I can't put two males together, so I need a female connector. That tells me usually that they need extra length, and that 7 foot isn't doing the job for them, because they're often also using extended oxygen tubing to get farther from the machine and get that extra length. So 7 feet long is normally not long enough. 10 feet is usually ideal, but we also have 14 foot. And both our 10 and our 14 foot have an adapter that converts us from male to female. All of our connectors also are both accepting of a Christmas tree or oxygen nipple, so you have a regulator that this can either screw onto. If it doesn't have a Christmas tree or oxygen nipple, it can just screw on, but if it does, you can just push this on and you will be attached. So that's your oxygen tubing, that's your CO2, and that's the split cannula with the Comfort Soft. We've just gotten new pricing so we can be extremely competitive. We used to have a product called the Blue Star. We're de-emphasizing the Blue Star because we've gotten so much better pricing on this. Blue Star was what we were getting from direct from China, and the delivery times were pretty hard. This is the adapter that I was talking about. This is a female by female, so when I connect this female here, now I have a sample line that ends with female, so I can attach it to another male connecting point or not use it. But it comes standard with the bag, so it's we have the ability to go to an IDN and say, hey, whatever SKUs you're using for your monitoring of procedural sedation, et cetera, any nasal cannulas that you're using for monitoring CO2, if you're using Salter, for example, they could be going through 10 different SKUs because various things, various connectors, various lengths, various packaging, whereas they can do everything with ours with either a 10-foot or a 14-foot. So we can connect a male-female, we can be longer, the length that they need it to be. When we get to our MAC anesthesia, which is generally what are we doing for most clinicians, when they do a procedural sedation, they'll start with a nasal cannula like we talked about, and that might be all they need. But if the patient's obese or they're having trouble oxygenating the patient, sometimes a nasal cannula, which only generates 30 to in the 30% range of inspired oxygen, maybe sometimes they need more control over their oxygen. So what they might do is they might choose the Capnoxygen mask or the Capno mask. The Capnoxygen mask here, we sell it with a sample line or without a sample line, and so what it looks like is a regular oxygen mask with oxygen tubing pre-connected, and the ability once again here to either screw it on or put it up to a Christmas tree adapter. But it also has inside of it a port that as you exhale, you'll capture the CO2 there. And I can either take my current sample line that's just hanging from my anesthesia machine, or I can purchase this with a CO2 sample line, and then I would connect it. But what they'll do no matter what is they'll connect this sample line here via this lure lock. It's firmly attached, so versus what they're doing normally is they're sending that catheter through one of these holes and then attaching the sample line to that, and that can easily get pulled out. This is secure and gives a high-quality CO2 waveform even at 6 and 10-plus liters of flow. So that's the Capno mask. I would recommend selling the Capno mask anytime you're talking to anesthesia and they already have sample lines where they don't need a sample line. Kind of an enhancement to the Capnoxygen mask is our vanilla-flavored Capno mask. And this is vanilla scented, and aromatherapy has been known to reduce the effects of anesthesia where they kind of have post-operative nausea and vomiting or POMV. So a patient that might have that might do better than inhaling the plastic smell of a traditional mask. This is infused with vanilla, so as I smell it, I get a faint yet evident vanilla scent, and that has been determined to be favorable to reducing nausea. It comes pre-attached with oxygen tubing and CO2 tubing attached, plus a filter. And what's interesting is our cost is actually lower for this system with the sample line and the filter than our cost for the Capnoxygen mask. So we are promoting this a little bit more because we get better pricing on it and it offers more features. A lot of facilities like the idea of the vanilla scent, and they of course like having everything pre-attached for them, so they just open it up and use it. It's also available in pediatric and also in a version where this is cut away and this is moved back, so an ophthalmic, so for eye surgery cases. So they basically cut away a portion of it and it just goes over the nose. So it's available once again for pediatric, adult, and ophthalmic. The Capno mask is also available in ophthalmic, but it's not available in pediatric. The last mask we have that we're going to talk about today is our POM mask, or procedural oxygen mask. This comes in a couple different flavors. We have it here in what we call the Elite, and it's pre-attached with an oxygen reservoir bag. I would connect my oxygen tubing here, and I would connect my CO2 tubing over here, right here. And a lot of times, once again, they have the CO2 tubing hanging from the machine. You would connect this to your CO2 monitor. And what this is only used for upper GI masks or procedures. The Capno mask and the Capnoxygen mask are generally masks that are in the $4 and under range. The POM mask is in the $8 range. So it's significantly more expensive, but it's for procedural sedation for upper GI procedures. So what they will do is they'll break through this initially, and then they might put a little lube here, and then they'll use a bite block, and they would send the GI scope through the opening here and through the mouth and into the esophagus or the trachea, depending on what they're analyzing. This mask with this oxygen reservoir has been known to be able to deliver up to 90+% inspired CO2. So what happens is I give oxygen here, it inflates this bag. As the patient actually inhales, they're getting oxygen from the supply tubing and also from the reservoir bag, and that increases their inspired oxygen percent. So once again, you're up in the 90% range with this. You're probably in the 70–80% range with the Capno mask and the Capnoxygen mask, and then you're in the 30% range with your nasal cannulas, or 30 to 40%. So once again, they'll always usually start with a nasal cannula, but if they need more oxygenation, they'll then switch to a mask where they can do higher flows. With a nasal cannula, you're generally doing about the max is usually about 6 liters of flow, whereas with an oxygen mask, either one of these styles, you're looking at oxygen rates of 6 liters, 10 liters, and above is very common. So that is a little overview of CO2 monitoring for Bell Medical and for patients. I'm going to take you, well, I just will let you all individually come off mute, and you're welcome to ask me any questions with regards to capnography. I'm going to also try to bring up one of our Road to Success documents so you can see that. So we're open to questions. I see one question was texted to me. Let's see. Yeah, sorry about the video quality. Let's see if I can bring up a different page here. Okay, hopefully you can see one of our Road to Success documents here that we send out that has to do with capnography. And it has basically, the very bottom, it has our intubated solution. Which has a little airway and a filter, et cetera, and we buy that from FlexiCare, I think. And then we have the Capnoxygen mask, and that can be with or without the sampling line. Once again, I usually sell the Capnoxygen mask when they don't want a sample line. And we can go up here, and here's our nasal cannula. We've added a couple other things with our nasal cannula. Once again, you can kind of see the split cannula there in the picture. We have a 10-foot and the 14-foot. We have a pediatric 7-foot and a neonate 7-foot. Those can come with male-female or whatever. So we've kind of expanded our offering there. Did someone have a question?
Yeah, Kevin, there's no documents on the screen right now.
Okay, thank you, sir.
The full screen.
Okay. Well, for some reason it's... Well, I'll send out the Road to Success documents that are appropriate. I'm not sure why it's not allowing me to do that.
Can you also send out the PDF that you, the PowerPoint that you just reviewed?
I can. Do you have any specific questions from it, or?
Well, I would just like to keep it on hand
yeah.
To review. And as a matter of you have others that you've done in other webinars, it'd be nice to have them all, and I'll just set me up a little, a little notebook with them in there.
Okay, I'll be glad to send those out. At any rate, does anybody have any specific questions with regards to capnography monitoring and how best to sell? My biggest recommendation is to identify your high usage areas, which would be the areas such as freestanding endoscopy centers, any GI lab within a hospital. Those are going to be high usage areas, and those are the areas that we want to attack aggressively. You want to identify what they're using now, and get that information to me, and I can help you create a strategy to win that business. We virtually can beat anyone in price, but we have a better device also. So we want to sell our quality, we want to sell our length, we want to sell the fact that we have both a male and female connector. So we really do have a good solution from a mask standpoint and a nasal cannula standpoint, and we have the ability to basically, the ideal scenario is when a customer tells you what they're paying now, because we'll undercut that by 3% or 5% or more, and you'll be surprised. You'll find some people, especially if they're using Salter, they might be paying, $80 or $3, $2.50 for a nasal cannula, and we can come in there and sell to them for less than $2, and even down to $1.30 in some situations. So. It's an excellent money bucket or opportunity for us. So contact, in fact, one of our Mark Everett's, our top sales rep for the last 2 days, is 2 months for getting new business. All he does is telemarket endoscopy centers and GI labs and hospitals. He identifies what they're using, sends samples, sends pricing, and we often earn their business. So